So I'm going to go over organizing patient care and what that looks like, especially for people who are new in the nursing homes, so you can understand what patients you see first, what kind of help they need, and what your clock hour looks like throughout the whole 24-hour day. So when you guys are charting as aides and you're charting in your point and click care or whatever system you guys are using, it's important that you know what level of care your patient's care plan states that they need. So you're going to have one of these items on whatever task you're performing. So you've got we've got bathing, ambulation, toileting, transfers, eating, dressing. And then we have the level of care that we have to provide for them, or what level of care they can provide for themselves. The lowest level of care would be somebody that's independent. Somebody that's independent, they're able to perform the tasks by themselves, but you have to monitor for safety and assist with gathering supplies, and also providing meals and activities as well. So when somebody is bathing and they're independent, you're going to have to grab their toiletries, you're going to have to grab their towels, their bath blankets, their clothes, all of that. And then you should monitor the patient while they're in the shower for safety reasons. The patients should never be in the shower all by themselves. And so as far as bathing goes, if they're independent, you still have a role with them. You're not just gonna give them their towels and let them go to the shower on their own. You still have to meet certain criteria. You might have to lay their washcloths out. You might have to remind them to wash up in the morning and at night before breakfast or whenever. You need to clean their glasses and check their hearing aids still, and inspect their dentures. You also want to inspect and clean their fingernails every day and their toenails, and ensure that they have clean clothes on. Just because somebody's independent in the facility doesn't mean that they're just going to do things all on their own. They still do need some assistance. You want to make sure that their hair is combed, and that they brush their teeth as well. With somebody who is ambulating independently, ambulation and activity I usually have under A. We want to encourage ambulation to and from dining and to and from all social activities, and encourage them to attend social activities. Toileting. An independent person, an independent resident toilets themselves, but you also need to assist with their brief changes and any type of peri-care they're going to need after you've changed their brief. Observe for skin abnormalities while you're doing their brief changes. That's really important. And you also need to monitor for bowel movements for charting purposes. So just because a patient goes to and from the bathroom on their own doesn't mean that you don't have any task to do there, because you still will have to make sure they're changing out their brief, make sure if they had a BM that you charted that, and make sure there's no skin issues. Transfers and turning is T. When somebody is independent, they usually need no assistance with transfers or turning and repositioning themselves in the bed or the chair. But you need to always be observing for their balance and gait to make sure that they're not going to fall or lose their balance, and also make sure that they have proper footwear and proper devices. So if they are running around barefoot, we want to encourage them to put on, some shoes or something on their feet that's non-skid to prevent falls. And then also, if they're missing their cane or their walker, you'll want to make sure they have that device. Eating. When somebody is independent for eating, that means that they generally will sit in the main dining room, and you want to encourage them to be social in the dining room and sit with others. You're going to serve their meal, but you want to observe for any changes in their intake or their swallowing ability. So if somebody's coughing or sniffling when they're eating, that might indicate that they have some type of swallowing deficiencies. And then, of course, you're still going to chart what they ate every day for every meal. Dressing. Independent person with dressing, ensure clean clothes are worn daily. They can probably get their clothes out and choose them, but just make sure that what they're choosing is appropriate for the weather, as well as something that they haven't wore multiple times in a row. That is independent. So you will have independent people in your facilities. They still need your help to do a lot of things. So that would be, or that's independent, where they don't really need you to do a whole lot of like physical stuff with them. The next level of care is supervision or standby or setup S. Supervision, setup, and standby requires that the staff supervision is there for either safety or cueing purposes. So either safety to make sure they're safe or cueing to tell them what the next step is if they can't remember. If somebody is supervised and set up with bathing, that is when the staff have to be there, gather supplies, set everything up, set up their washcloths, set up their soap, anything that they're going to need. Clean their glasses, check their hearing aids, same as before, inspect their dentures, inspect and clean fingernails and toenails, ensure clean clothing is worn every day, tidy up their room if needed, comb their hair before leaving the room, make sure they brush their teeth. With setup, with brushing their teeth, you may have to set up their toothbrush and put the toothpaste on it, or tell them how to do it, cueing them. Ambulation and activity. For supervision and setup, you want to encourage ambulation to and from the dining room, walk with the resident to and from all social activities. If they're standby for walking or ambulation, you want to make sure you're walking with them. You don't necessarily have to touch them or hold their hand or help them with their balance. You just have to be there for supervision and cueing for safety. Toileting for supervision require supervision in the restroom every 2 hours and as needed. So if somebody's supervision with toileting, you want to make sure you put them on an every 2 hour toileting schedule where you're at least encouraging them or asking them to use the toilet every 2 hours. That prevents them from having accidents and makes sure that you have your routine so that you're not interrupted in the middle of your tasks. They might need cueing as far as what's next. Is it time to wash my hands? Now it's time to wash your hands. Now dry them. You will have to always assist with brief changes in pericare as necessary. They may be able to wash themselves, but you need to be there for that, and you might need to also tell them what to do. Observe the skin for any abnormalities as you would all of the other levels of care, and you'll need to monitor bowel movements just like we talked about the other ones. Transferring and turning as a setup or supervision. You want to set up the wheelchair or walker, and you might even just need to cue them and just say, here's your walker, go ahead and stand up. You want to observe for gait changes and balance and ensure proper footwear, of course. Cueing for turning and repositioning every 2 hours is needed in the bed and the chair. So your patient, you don't want them sitting in one position for too long, and they just might need to be told to change their position to prevent any type of sore from forming. With eating, we're going to set up their meal tray. We're going to cut their food up. We're going to make sure there's any condiments on there, how they want them. Observe for changes in intake and swallowing ability. They may require cueing for eating. You may have to tell them, okay, now let's take another bite, or let's take a drink. And then, of course, dressing, you just want to make sure clean clothes are worn daily, and you may have to also assist with putting the clothes on. So that is supervision, setup, or standby. So we have independent, where the patient does most everything on their own. You're there for, safety purposes. Supervision and setup, you're there for supervision and possibly assisting with some of their things that they need. Limited is when we start having to touch the patient. These two, we don't have to touch the patient. We can just hand them stuff and tell them stuff and help them in that way. Where limited, they actually need your physical touch to help them. Once you've touched your patient, whether you be holding their hand or touching their back for support, or holding onto their arm to help walk with them. As soon as you touch your patient, you've automatically provided limited assistance for that patient. If they're independent or supervised, where you don't need to touch them, but let's say you have to, like you're going to hold their hand and guide them down the hallway, then that turns it into limited for ambulation as soon as you touched them, okay? This is called limited assistance or minimum assistance. And this is where they require the staff to guide their limbs and touch. You're not using muscle at this point. It's only simple guide with your hands to guide them to do what they're supposed to do. Limited with bathing requires that the staff bathe the patient, but encourage their independence. You might have to wash their back. You might have to wash their hair, help wash their feet. As long as you're not lifting on them or providing muscle, it's still limited assistance, just guiding them. Handing them the washcloth and putting it up to their face, or putting the shampoo in their hand and helping them wash their hair, or whatever you got to do. That's limited assistance or minimum. Grooming, you need to physically brush the patient's teeth, or guide their arm as if they were doing so. So you're going to get the toothbrush ready and you're going to put it in your patient's hand, and your patient's going to hold on to it, and they're not going to know what to do. So you're going to take your hand and you're going to pull it up to their mouth, and you're going to assist them with brushing their teeth like this. And you're going to assist them with combing their hair. You're going to put the brush in their hand and you're going to comb their hair with them. That provides that, or promotes their independence, as well as assists them limited. You want to make sure you keep their glasses clean, check hearing aids, inspect dentures, inspect fingernails and toenails, ensure clean clothing are worn every day, tidy up the room if needed, comb hair before leaving the room, ensure oral care is complete. So bathing, getting them ready, groomed would all be something that you have to physically help brush their hair and help do that stuff for them. Limited for ambulation and activity. If somebody's limited in ambulation, you're going to ambulate them with or without an assistive device, and you will be there to support and guide them and touch them. And the way that you're going to touch them is you're going to have a gait belt around their waist, and then you're going to hang on to that gait belt, and that prevents you from having to put your arm under their arm and create maybe possibly a bruise of some kind. Or even if they were to fall, it would prevent you from hanging onto their shoulder, possibly injuring them in some way. So you have to wear they will have to wear the gait belt. The resident will require assistance to and from the dining room and to and from social activities, as well as to and from the restroom. So you're going to have to gait belt them every time, and then you're going to assist them with ambulation using that gait belt. You may also be taking them to and from somewhere in their wheelchair. So consider whether or not you used limited or extensive assistance to get them in the wheelchair. Toileting requires that the resident uses the restroom every 2 hours and as needed, at least every 2 hours, and then as needed in between. With limited assistance, they're going to need assistance getting on and off the toilet, as well as wiping and hygiene care. You have to do a brief check and change, and clothing changes as well, so you'll help them with getting back dressed. Hand washing with assistance. So when they're done using the bathroom, you're going to help them get up to the sink, and you're going to help them get soap on their hands, turn on the water, help them wash their hands. You may have to physically take their hands and rub them together to wash their hands. Observe for skin abnormalities, monitor for bowel movements, for charting purposes. And then that's limited assistance with toileting. Limited assistance with transfers and turns requires the staff to guide the limbs to the walker or the wheelchair for transfer using your gait belt. Anything above supervision needs a gait belt if they're going to be walking. Queuing if necessary, ensure proper footwear, etc. Queuing and assist for turning and repositioning every 2 hours. You may have to help the patient maybe roll, but as long as you're not using your muscle, it's limited assistance. You're touching them with no muscle, that's limited. But if you end up having to help them turn in the bed and you end up having to use your muscle to hike them up or whatever, that automatically turns into extensive assist.
That's what was going to be my question next.
Mm-hmm. Eating with limited assistance, you're going to set up their food tray, cut up their food, condiments, observe for any changes in swallowing ability and intake. You need to sit at this point next to the resident and offer assistance or cueing with limited assist. They may need you to put the food on the utensil and put it in their hand and then guide their mouth or their limb to their mouth at that point. If they can do it themselves, then that's what? Independent.
Independent, yeah.
Or supervision, depending on their ability. Dressing, when somebody is limited assistance, ensure that clean clothing are worn every day. Assist with guiding their limbs into the clothing. So you're going to assist with their arm. You might help them put it in their shirt or something like that. So, independent, supervision, limited. This is touch. Extensive assistance is when you're using muscle to help them. This means for bathing, the resident part, see the difference between extensive and dependent is what the patient's ability is. If the patient can help you and they assist with this, even though you're lifting them and doing it for them, if they can help you and they helped you, that's extensive. If they can't help you and didn't help you, then they are dependent on you.
Okay.
So that's the difference between these two higher levels of care. So with bathing, the extensive resident, the staff will bathe them and encourage independence. So anything they're able to do, you want to encourage them to do. Like if they can wash their face, that might be all that they can do is wash their face and their hands. So let them wash their face and their hands. You may end up doing the rest of the bath, which then is an extensive assist. With grooming, you'll physically brush their teeth. You'll have to actually physically do that for them. And their hair. Of course, we always clean their glasses, check hearing aids, inspect dentures. Clean fingernails and toenails. Ensure clean clothing are worn every day. Tidy up the room, comb hair, blah, blah, blah. With ambulation and activity, when somebody is extensive assist, it requires the gait belt and 1 or 2 staff assistants for ambulation or assistance getting to and from the wheelchair, depending on what they have. They do require assistance to and from the dining room and social activities as well as to and from the bathroom. With toileting, the resident requires physical lifting assistance in the restroom every 2 hours and as needed. They also need assistance with getting on and off the toilet as well as hygiene care and wiping. You'll need to do brief check-in changes if they have briefs or are incontinent, as well as any clothing changes that may ensue from using the restroom. Assistance with washing their hands. You might be grabbing a washcloth with soap on it and like physically just scrubbing on their hands and then rinsing them off. And then of course charting bowel movements, etc. With transfers and turning, an extensive assist requires the staff to physically lift them into the chair or to lift them doing the transfer using the gait belt. Cueing as necessary, ensure proper footwear, etc. Physical turning and repositioning every 2 hours may also require 2 staff members. So you might have, this person might be extensive 1 for hygiene care or bathing, so it just takes 1 person to bathe them. But in order to move that human in the bed, you're going to, for safety, need 2 people extensive. So then you're going to chart that you used extensive assist with 2 people. Even though it might even just say one assist. Using 2 is fine, right, for safety? For eating, you're going to set up their meal tray, cut up their food, condiments, anything that they need, observe for swallowing ability and intake changes. Sit next to the resident and offer assistance with eating and drinking. This person you're going to be, if they're extensive for eating, you're going to be actually physically feeding them. If they participate in that, then they are extensive. It's extensive assist. You're also going to help them with drinking. And then with clothing and getting dressed and that type of thing, it's going to be 1 person assisting to get them dressed. But if you use 2 people, which is fine, chart 2 people, even though they only need 1, right? All right, dependent. This is the person that cannot help you or does not have the ability to assist you in what you're helping them with. Resident does not participate. That means if you didn't do this for them, they would not have it done. because they can't do it themselves. Staff provides total assistance with bathing, provides total grooming, total oral care, hand and nail care, and foot care. Ambulation and activity. This person generally requires a mechanical lift. And if a mechanical lift is required, they need at least 2 staff members legally. But if it is a different type of lift where only 1 staff member is needed, then that, might be a little bit different. But then they might go from dependent to extensive if they're helping stand, like for a sit to stand, I guess. Mm-hmm. 1 or 2 staff assistants with ambulation with the wheelchair. If you're going to push somebody's wheelchair, it should just take 1 person, and then you're extensively helping them transfer or ambulate through the facility. Requires assistance to and from dining, social activities, and to and from the restroom. And if you're doing like a check and change where the patient's in bed and they're dependent and you're just checking their brief and changing them and cleaning them up, that's dependent if they cannot help you. Resident requires for toileting of check and change of their brief in the bed every 2 hours and as needed. Can also include pericare and dressing. Hand washing assistance. Just because they didn't participate doesn't mean that they shouldn't wash their hands after you're done toileting with them. They should always have that opportunity to wash their hands when they're done. Observe skin for abnormalities. Also report bowel movements. Transfers and turning. The resident requires mechanical lift. And 2 staff present for safety. Ensure proper footwear and safety devices. Physical turning and repositioning every 2 hours may require 2 people. For eating, the only time you would mark somebody dependent for eating is if they're on a tube feed or IV nutrition. But if you put the food in their mouth and they're chewing, they're helping you, that's extensive for eating. So somebody dependent with eating would be on a tube feed of some sort. Or NPO. Which means what?
Nothing
by mouth. Yes. Dressing, you're going to completely dress the resident and do clothing changes and make sure there's no wrinkles and all of that kind of stuff. All right. So now I'm going to take you through the daily clock and kind of show you what it should look like every day. In a nutshell. So the morning shift starts anywhere between 6 and 7. Usually 6:30, there's a shift change. When you come on in the morning shift, you have about 15 to 30 minutes to get report from your the aide that worked on your unit before you got there. The group you're going to take over when you start working. So you're going to sit with that person in a very private area and you're going to talk about the patients that they're giving to you under your care now. They're going to tell you things like this. Did they give him a bath? Did they walk? Did they toilet? Did they transfer? Did they eat? Are they dressed? What else do they need for the rest of the day? So you're going to get information like that. You're going to get information on their bowel movements, on when they went to the bathroom last, when they were checked and changed last. My recommendation, and I'll always say this till the day that I die, the best way to do report is to do bedside report with both staff. I say this for a couple of different reasons. I think number one, it keeps the length of the report at a minimum because there's no extra like fluffy like stuff. It's facts only, objective information. You're not sitting and visiting and giving extra information that's unnecessary. You're sitting down together, you're going through your batted, what the patient needs, what they did. And so then the next aide will know exactly what to do with them. But I say take that half hour, because as soon as you come on your shift, everybody's going to get up and have to go pee, or they might need check and changed at 6 o'clock. So you're going to have that second person, they're your personal assistant for 30 minutes. Go into every patient room with them, give report together with the patient present. So then that cuts down on people being inappropriate during report, which happens all the time. You're giving objective information with the patient's input, which is very powerful for them to be able to give input on the care that is being given to them. So you'll have you and that other person. You're going to go every single room to room. You're going to give report with the patient and check and change them. Sometimes when you come in the morning, you'll have a handful of maybe 4 or so patients that have already been what's called top dressed, where midnight shift had to toilet the patient every 2 hours as well, or had to check and change them every 2 hours as well. So probably about 4 or 5 o'clock in the morning, they might just wash up their upper body and put on their shirt. They would leave them in the brief, and then at 6 o'clock, you're going to change that brief because it's been 2 hours. And then you'll pull up their pants, and you have that other person there with you to help you do the 2-person transfer, get them in their chair, and get them down, to wherever they're going to go wait for breakfast. So that's my recommendation if you guys would like a smooth shift full of no question. And that's probably the best way to do it, is to go together and go check and change all your people together, get report on all your people together. Saves a lot of finger pointing when something happens in the meantime and nobody wants to admit to it. Like if somebody's soiled or whatever,
Well, this is all good information. The company that I'm working for has me going into subcontract with a couple different nursing homes after I get done certification here.
Oh, yeah.
So
not a lot of people like to do bedside report, but I think it's the standard that should be set.
okay.
And I know a lot of hospitals do it right now.
Okay.
So 6 o'clock, we're going to go through, we're going to get our report. We're going to check and change all of our people, turn and reposition anybody that needs turned and repositioned, anything that you got to do every 2 hours. And then you're going to start getting your group up for breakfast. So you want to take note on who likes to get up early and who doesn't like to get up early, because some patients might not want to get up until 7 or 8. So what you're going to do is you're going to take the patients that want to get up now, and you're going to start getting them ready. You might have one person that's independent, one person that's supervised, probably 3 people that's limited, 3 people extensive, and maybe 1 or 2 that's dependent, just to kind of give you an example of what your patient load might look like that day. So, hold on, I have my other. So then right after you get report, you're going to start doing your AM care. AM care consists of bathing, toileting, dressing, transfers to get them down to breakfast. About 9 o'clock is when they're going to eat breakfast, and then that's when they're going to get their ambulation in, because we're going to walk them to and from the room for people who need ambulated, or for those who have the order to be walked 4 times a day or 3 times a day. We're going to walk with them to and from the dining room. After all of the residents are in the dining room, some of the residents will also be eating in their room. So at that time, you're going to be working with possibly 2 other aides. One of you is going to stay on the hall to answer call lights and to assist in the dining, or with their dining within their rooms. And then the other ones are going to go and assist in the dining room with those who need assistance in the dining room. At that point, if you check and changed and turned and repositioned everybody at 6, you're going to check and change and reposition everybody at 8, or before you take them down to breakfast. One thing that's really important that you want to make sure you do is toilet them before the meal. So before every meal. So let's say breakfast is at 9, we'll say 9 noon, and dinner's at 4, whatever. You want to take them to the toilet before they go to the meal, because if you don't, when they get down there, you're going to be running around passing food, helping other people, and they're going to be like, hey, wait, you got to help me. And then you're going to have to take them away from the table, away from their friends that they were socializing with, possibly away from their food. They might be embarrassed to take them to the bathroom. So I just think it's really important that you take them before they eat. And then again, after the meal is over, you're going to offer toileting again. So every 2 hours, we'll just go like this. Toileting, turning, check and change every 2 hours around the clock with all of your patients. Now we are at, so 10 o'clock, after everybody's done with the dining room, you're going to reevaluate your group of patients and see who else you have to do yet, because you're not going to be able to get all your patients ready and bathed before breakfast, not unless you're really good. You're going to have a couple people that want to stay in their room. They might want to get ready later. And you're going to have some people that you just didn't have time to get to at that time. So you're going to have to finish all your AM care sometime before 11-ish. Because 11-ish starts your new prep for meal. When you prep them for their meal, you want to wash their hands and face, offer toileting, and make sure that they're ready to go. Lunch, of course, will be the same situation as breakfast, where, you'll either be in the hall or you'll be in the dining room. You might switch throughout the day. 2 2 o'clock, generally a shift change. So around 2 o'clock, 2:30. This is when you're going to do the same process again, where you're now handing your patient off to somebody else. I'm just like assuming you're working first shift, but I know you won't all be working first shift. So assist your staff, the staff coming on with your check and changes for a half hour or so. And you can prepare for that before they even get there. Just make sure you have your independent people toileted, and anybody you can do on your own. And then save the people that are to assist for when your shift change happens. And then you'll have a to assist, unless of course you can get a second person on the unit, but they're also doing the same thing you're doing. Right. So you might have to meet in the middle at one point and ask somebody else for help, which is totally fine. When second shift begins, you want to make sure that if that's your on the hour, you might want to make sure everybody's turn to reposition, check and change, right? Because that's your circled time every 2 hours. Anybody that is a second shift bath, some people are going to want to take their bath at night, and some of them are going to want to take it right away before they eat. A lot of the residents in the nursing home want to get ready for bed at 6 o'clock. As soon as that dining room's cleared out, they're lined up down the hallway at the bathroom trying to get help so they can be toileted and changed and get ready for bed. So you kind of want to prioritize your patients as far as like what they want to do. Because, right, we want to go with what they want, not what we want, and not with our times. But you can arrange it so that it works perfectly, because you're going to have people that want to get ready, and you're going to know who they are. And you might even possibly get them ready in this area over here before the meal. But make sure that they're at least toileted, hands and face washed before the meal. About 6 o'clock or so, everybody's going to be in the dining room or eating. One other thing I forgot. When you first come on your shift, maybe between 2 and 4, you're going to want to change out everybody's water. It's your responsibility to make sure everybody has fresh water.
Pass the water on here?
Yep, that's what pass water. Yep, pass water, pass linens. So what that means is if you have patients that like to bathe themselves in the bathroom or need just help bathing in their room before bed, you're gonna set out their washcloths in their room. You're gonna put their gown or whatever they're gonna wear at night. Have that all ready in their room so that when you make it around to their room, your stuff's already in there. That's totally fine to do that. Prepare a patient for the meal. Again, I think I got that far already. And then you're going to assist in either the dining room or the hallway. About 6 o'clock, sometimes there's a shift change at 6 o'clock. Not always. It depends on if you're working 12 hours or 8 hours, but I kind of made this form so you can see where both shifts fall, or where the shift changes fall. When you first come on your shift, or when somebody's leaving their shift, you want to go through and check and change everybody, because that's usually what you need 2 people for. After everybody's out of the dining room, now it's time for the PM rush, where everybody wants to get ready for bed. And it's going to take you a little while to get everybody ready for bed. And then usually about 9 o'clock, there is a snack of some kind that's offered to the residents. So you'll assist with that. And about 11 o'clock, that's a shift change. 10 o'clock, 11 o'clock is another potential shift change. So then you would go around, do your half-hour report, your check and changes. And then after that, your patients, once they're asleep, they're just bed checks once every hour. A bed check is it's different for each person, but what it consists of is you making sure that the patient is present and alive. They're present and they're alive and they're sleeping. And then you'll chart your check and changes. You do check and changes too, but you'll chart your bed checks as well. Just patient is present, respirations observed, whatever. About 5 o'clock or so in the morning, a lot of facilities have it against their policy to get a patient up out of bed before 5 o'clock, before 5 a.m., unless it's in their care plan for them to get up earlier than that. You will have a lot of patients that like to get up at 5, some of them 6. So once you get to know what their needs are, it'll be a lot easier for you to organize that. What do you think? Any questions?